So yeah, this is a phase 1b/2 clinical trial conducted at MD Anderson, looking at the triplet regimen of Azacitidine, Venetoclax, and Magrolimab in AML. So Magrolimab is a CD47 antibody. CD47 is a receptor that's ubiquitously expressed on myeloid cancer cells, and Magrolimab has been studied in combination with Azacitidine in TP53 mutated AML and shown encouraging efficacy and safety. And there has been preclinical data from our group at Anderson of using the triplet, Aza, Ven, and Magro together, and it has shown synergy in the preclinical setting. So based on that, we conducted this phase 1b clinical trial with a particular focus on high risk and adverse TP53 mutated AML. So we enrolled patients in 2 cohorts, frontline and relapsed refractory. The frontline cohort had about 54 patients. 65% of those had the TP53 mutation. Even the ones who were TP53 wild type actually had 60-65% of patients with adverse risk karyotype. So basically goes on to see that this was a very high risk frontline cohort. So looking at the response rates to the regimen, we had a composite complete response of around 90% with the TP53 wild type patients and about 49% with the TP53 mutated patients. So this was pretty encouraging, but unfortunately the survival outcomes did not really come up to what we had expected. We saw a median OS of about 8 months only for the TP53 mutated cohort, and for the entire cohort it was only about 10 months. We did see that among the patients with TP53 mutation who underwent allogenic stem cell transplant, there was an improved survival with a 1-year OS of about 73% and median OS that was not reached. So I think the key thing that we'll be presenting at ASH is the correlative data when we looked at single cell sequencing of TP53 mutated samples to evaluate the mechanisms of relapse and resistance to the trial regimen. We found some really key findings. First, we looked at the baseline T cell function and activity in responders and non-responders. We saw that patients who had higher levels of gamma delta T cells and more signatures of dysfunctional CD8 T cells were more likely to not respond to treatment with Aza and Magrolimab. Since Magrolimab works partly by inducing phagocytosis and stimulating macrophages, we also looked at the baseline macrophage activity and function in non-responders and responders. Interestingly, again, we found that in patients who did not respond to treatment with Magrolimab, they had reduced baseline macrophage activity, both antigen presentation and phagocytosis. Also, the levels of HLA-1 and HLA-2 were both reduced in patients who were non-responders. Also, patients who initially responded and then relapsed had a loss of their antigen presentation and macrophage activities. So all of this saying that Magrolimab does work, and as an on-target mechanism by stimulating the macrophages, and you need healthy macrophages for it to have an activity. And finally, we also looked at the cellular states of the malignant cells at baseline for responders and non-responders, and we saw elevated inflammatory signaling, including TNF-alpha, interferon gamma, and heme metabolism pathways in the malignant cells in patients who did not respond to treatment. Again, showing that inflammation could be a predisposing factor to resistance to these therapies. Finally, and I think one of the most important findings that we generated here was that the erythroid differentiated phenotype was seen more commonly in non-responders and at the time of relapse to patients with Aza and Magrolimab, especially in TP53 mutated AML patients. So I think even while this trial we did not achieve the survival benefits that we had hoped for, I think we have generated a lot of important correlatives, especially that erythroid differentiated AML among TP53 mutated AML is a particularly aggressive and high risk type of AML, and those patients might have to be analyzed and grouped separately for future clinical trials and may not be the best candidates for CD47 antibody based therapies. Thank you.